Dr. Cooney is an assistant professor in the UW Department of OBGYN, which is where we work, and she's specifically in our reproductive endocrinology and infertility division. Dr. Cooney specializes in female infertility, fertility preservation, third-party reproduction, and of course, polycystic ovary syndrome, PCOS, which is why we are all here tonight. Dr. Cooney works at the Generations Fertility Care Clinic in Middleton, and she's also the founder of UW's multidisciplinary PCOS clinic. Thank you, Dr. Cooney.
So can you guys hear me? Okay.
Yeah.
A little bit more, because we have a microphone in case you think that would be better.
I think you're okay.
Yeah? Okay. If you're in charge of the voice, so like I'll look at you every few minutes and you can just go like this. Great, so I am super excited to be here today. As she sort of said, I'm a reproductive endocrinologist. So it means I have a background training in gynecology, OBGYN, and then I did my specialty in reproductive endocrinology, so basically focusing on hormones kind of the reproductive system in women. I initially got interested in PCOS years ago when I was seeing a lot of women who were coming to see me and they were frustrated with the diagnosis, they were frustrated with a lot of the symptoms, and also kind of confused because a lot of these symptoms had been going on for a long time and they didn't really understand how they all fit together. There's been studies that have looked specifically at this. A large national survey of women with PCOS found that a third of them ended up having taken more than 2 years before they had the diagnosis of PCOS. Half of women had seen more than 2 different providers before being diagnosed with PCOS. And it's not too surprising when you think about all of the different providers that someone could see. So if someone's coming in with irregular periods, they might see their OBGYN, they might see their primary care doctor, someone with hair growth might go directly to a dermatologist. And so it becomes really difficult to put all of these different symptoms together to figure out what's going on. And so I felt like because of our sort of special interest in hormones, in reproductive aged women, with a background in fertility, which some but not all women are kind of interested in, a reproductive endocrinologist is sort of the perfect home base to help women with PCOS. So my goals today are to sort of explain what PCOS is. I'm sure people are coming at it from lots of different standpoints. Some of you may have spent like hours and hours researching online and like could give this talk, and other people might be trying to decide if they have PCOS. So one of the other things is to think about, do you need to talk to your doctor about PCOS to see if you need any other tests done, to kind of give you guidance on a lot of that stuff. And then I wanted to talk about some of the long-term health complications of PCOS and potentially any treatment options. So that's my goal. PCOS is actually incredibly common, but a lot of people don't know it. So when you think about the endocrine disorders that everybody is talking about, we're thinking about diabetes, we're thinking about hypothyroidism. If you look at 100 women, about 1% of reproductive age women have hypothyroid, 4% have diabetes, 10 to 12% have PCOS. So again, it's an incredibly common disorder in young women. It's also everywhere. So a couple of years ago, we did an analysis looking at risk of depression and anxiety in women with PCOS, and we were looking at studies that were kind of published all across the world. And so there were over 30 studies on this topic alone, so depression and anxiety in women with PCOS, in 10 different countries, looking at more than 3,000 women. So again, this is not something just affecting people in the United States, it's really all over. So one of the myths about PCOS is the concern that women with PCOS have more ovarian cysts. I have people coming in who have a history of pelvic pain, who've been seen in the emergency room for a ruptured ovarian cyst. And it's important for us to realize that it's just a really bad name. So polycystic ovary syndrome, we're not talking about more cysts, we're talking about more follicles. And so to kind of go over that, we have to think back to when we first learned about the reproductive system. This is a joke because nobody teaches this in health school ever, but this is, our ovary, the uterus. This is my rendition of the ovary. So basically, all women are born with thousands of immature eggs. And each month, some get surrounded by fluid. Those are the follicles. And then your brain makes follicle-stimulating hormone to get one of those follicles to grow. The egg inside becomes mature, and then it ovulates into the fallopian tubes. And this is what a normal ovary looks like. So you can see up here all of these small little black dots, those are follicles. When you measure them, they're typically less than a centimeter, so these are really small. This is a cyst. So lots of different types of cysts. This is one, that's simple. Sometimes they're filled with fluid, blood, other crazy things, and they can be painful, and they can sort of rupture and twist and cause lots of problems. And women with PCOS can absolutely get ovarian cysts just like everybody else. But when you think about what their ovaries look like, this is actually what an ovary looks like, someone with PCOS. So again, you can see it's very different than these big cysts and very similar to a normal ovary. It just has more of these little follicles. So for the criteria with PCOS, which we're going to spend a lot of time talking about because it's very complicated. For diabetes, you get one blood test and you're like, okay, you have diabetes. With PCOS, there's a million different tests. There's a lot of either or. There are actually very clear international guidelines about how to diagnose PCOS, but it doesn't make it any less complicated. So I'm going to go through some of it today just so you guys can think back a little bit to your history and again help you think of other questions for your doctor. So for PCOS, the criteria for the ovaries are more than 20 follicles or a volume more than 10 centimeters. So again, no cysts, just more follicles, which means eggs. So this is again part of normal fertility and sometimes a little bit larger. So again, not cysts, follicles. There was some probably radiologist like 100 years ago who named it PCOS, and now I have to spend 5 minutes every single day explaining it. So thinking back to your history, have you had an ultrasound? Do you know how many follicles you have? Sometimes radiologists don't count, but sometimes I can look back at images or videos of someone's ovaries and kind of give them an idea. So that's one of the 3 criteria. A lot of people think that being overweight is one of the criteria of PCOS, and we'll spend a lot of time talking about it, but it's actually not. So some women with PCOS are more likely to be overweight, but it's not one of the 3 diagnostic criteria. So the other 2 are irregular periods and signs of elevated testosterone. So when you ask the question, do you have regular periods, it's sometimes hard. A lot of people don't know if I'm talking about like how long they bleed for, how heavy it is, how painful it is. So the best questions that are part of the sort of diagnosis of PCOS are thinking how many days between the start of one period and the start of the next, and everyone can like think about this now. What's the longest you've ever gone without a period? Obviously when you weren't pregnant or on birth control, and how many periods do you get in a typical year? So normal is between 21 to 35 days. And so if someone generally has periods that are either coming really close together or really far apart, if they go more than 3 months without getting a period, or if they have less than 8 in a year. You don't have to have all of them, but one of these 3 kind of fits that criteria for PCOS. The tough thing is that there are a lot of things that cause irregular periods. And so it's also important for us to make sure we're not missing something else. Sometimes this can be determined just by talking, getting a history, and sometimes there are other blood tests. So the things to think about if you're trying to make sure we're not missing something else that could be mimicking PCOS are looking at the thyroid levels, prolactin. There's a test called 17-hydroxyprogesterone, which is a specific type of progesterone made by the adrenal glands and not the ovaries that can mimic PCOS, as well as other sort of reproductive hormones. So then the last criteria is anything that is evidence of elevated sort of male pattern hormones, so any of the androgens. So the most common ones are free testosterone and total testosterone. If those are elevated, that's enough for the diagnosis and you don't need anything else. But sometimes I have someone coming in who things are a little bit irregular, we're not quite sure what's going on, and so there are a couple of other hormones that can sometimes be helpful if we're really trying to get to the bottom of the diagnosis. And then there are also clinical signs of elevated androgens. So this can be abnormal hair growth, or the doctor word is hirsutism. Cystic acne, so this is really more of the like pustular acne, not just sort of a couple here and there. And female pattern hair loss, which is frequently more central. There's a scoring sheet, which I'll show you in a minute, for the hair growth, but not for acne or hair loss. So sometimes it's a little bit hard for us to decide how much of that meets criteria for PCOS versus how much of it is normal, but it all can kind of be part of the same picture. So whenever someone comes to see me, we have this fun scoring sheet to do, looking at hair growth in specific places, so above the lip, chin, chest, upper abdomen, lower abdomen. The upper arms specifically, not the lower arms. Everybody has a lot of hair on the lower arms. Inner thighs, upper back, and bottom. And so this can kind of help distinguish what's normal or not. So we're looking not just at like peach fuzz, so everybody has, a lot of light hair. We're looking at dark, kind of coarse hair that if you let it continue to grow, it would grow more than a centimeter. Sometimes that's hard because most people don't want to let their hair grow for more than a centimeter, but a lot of times usually we can kind of come up with a score for this. So those are the 3 criteria for PCOS, and to make it even more complicated, you only need 2 out of the 3 of them. So what this means is that there are a lot of different presentations for PCOS. So some people have all of them. Some people might have hair growth and irregular periods. Some people might have totally normal periods, but have some hair growth or acne and the follicle count on the ultrasound. And some of their kind of risks for problems are very different. So someone with regular periods is actually not going to usually have problems getting pregnant because they are going to be ovulating every single month. Someone down here, who doesn't have any clinical or outward signs might be less likely to get diagnosed early on. They've always had irregular periods, but then they went on birth control pills. And so it's been 10 years, they're finally kind of stopping their birth control pills and they're realizing that their periods are irregular. And then they remember, oh yeah, they've been irregular for my whole life. But you can imagine how it can be hard to kind of finally get these people diagnosed. It really matters. So sometimes I'll see women who were told, I might have PCOS. They've been mentioning it for like the past 10 years, but I just don't know if I do or I don't. And my goal is to really just get to the bottom of it. So either there's a diagnosis or there's not. If there's not, that's great. You don't have to worry about it. But it's nice just to know. And I don't want to scare people, but the reason it's nice to know is because there's a lot of long-term health complications with PCOS. So some of these things are things that we talked about, that just go along with the diagnosis. But other things are looking at long-term health complications, so impaired glucose tolerance or diabetes. When people get pregnant, risk of high blood pressure, preeclampsia, risk of sleep apnea. So you want to make sure that you're screened appropriately for these kind of things. Like everything, most women with PCOS don't have these problems, but you want to know, if you do or if you don't, and how often you need to get tested. One of the other myths is that PCOS only affects women in the early or like middle adult years. And that's not true. There have actually been some really good studies that show that even after menopause, women with a history of PCOS still have increased risk of health complications. So things like diabetes, high cholesterol. So sometimes women come to me and they say, I'm done having kids. Why does this matter? And so it's important to think about how often should you be screened for things like diabetes, cholesterol, and all of that. This is really tough, right? I wish I had a really good answer for this. Again, there are some really conditions that are easy. You know, you break your ankle and you like know how that happened usually. With PCOS, it's a lot less clear. So it seems to be this really dual interaction between genetics and the environment. And some of the genetics are literally what we think about. So women with PCOS are more likely to have a sibling with PCOS or other relatives. And some of it is actually what we were exposed to when we were in our mom and she was pregnant with us. So there have been really interesting studies looking at, mom's levels of testosterone or other hormones and how that affects her daughter's chance of getting PCOS in the future. A lot of the environment seems to center around something called insulin resistance. So insulin is that hormone that when you eat, it brings the glucose, the sugar from your blood into your cells. And women with PCOS seem to have, their bodies aren't as good at bringing that insulin into the cells. So you get higher, or glucose into the cells. So you get higher levels of glucose in the blood, and that is really connected to the production of testosterone. So it's this really big kind of circular thing where the testosterone and insulin resistance are really connected. So not clear cut, because you can imagine, like everything, each woman has a different kind of combination of some of these different risk factors. There's a lot of really good studies that are going on now, some of them in like mice models. So maybe in a decade we'll know a lot more, but this is kind of the best we have right now. There's not really a cure. I've had people come in and talk about different treatment options and say, I don't want a Band-Aid. I really want to get to the root of this and fix things. And sometimes that's tough, and I think it's important to think about, what are the treatment options that we're doing for PCOS. Most of the time it's focused on what are the problems that are causing someone the most distress. So treatment for someone with hair growth is going to be different than treatment with someone without. Someone who's interested in getting pregnant now might not be able to focus on the same types of things as someone who's not ready for 10 years. I don't want to put a Band-Aid on symptoms, but I think it's also important to think that some of the hormones, medications we use, like birth control pills, do actually get to the root of a lot of the problems. So thinking about the elevated testosterone, birth control pills increase the binding proteins in the blood that bind testosterone. So it can actually decrease circulating levels of testosterone. They can impact the conversion of hormones to testosterone. So again, they're still getting at the root of the problem, even if they're also helping you with your periods. So I was going to spend a little bit of time talking about some of the health complications that people are most concerned about. There's obviously a long list, and we can kind of get into anything that I skip later on that people want to talk about. One of the most frustrating things with PCOS that a lot of people worry about is the weight gain. But not all women with PCOS are overweight. So about 60% of women are, which means 40% aren't. But what's incredibly important is that the long-term risks that we talked about, diabetes, things like that, are increased in women with PCOS regardless of their weight. So no matter what, everybody should be screened for these. I think it's also important for people to know that the sort of lean PCOS phenotype, women who are not overweight, it doesn't mean that they're going to start gaining weight. So just because someone was diagnosed with PCOS, you don't have to necessarily worry that you're going to start gaining more weight. I wish there was sort of a magical diet. I've had a lot of people who come in who've had really good success with one diet or another, but no studies have sort of clearly demonstrated the best improvement for weight loss in women with PCOS. I was just reading something the other day, this sort of large trial, not in women with PCOS, but in general for weight loss, comparing a low carb diet and a low fat diet. And the outcomes, everybody lost weight, they were the same. So it's gonna be different for everybody, and my goal really is to find the best kind of combination of everything that works for you. What can we sustain? And some people can sustain some of the sort of intense diets. I I couldn't. I like intermittent fasting, it just worries me that having these like major peaks and troughs in the amount of glucose and sugar going through your body. We already talked about how important insulin resistance is for PCOS. You can imagine if you hit your body with these big glucose loads and then you fast for hours, that can't be good. So again, one of the things that I like to kind of do with people as we're working through this is find a combination of sort of healthy eating that works for them. I had someone say the other day that she was happy that she finally found someone who wasn't like sitting on her shoulder as she was like walking through the grocery store telling her she couldn't eat things. So my goal is to make something manageable for people, not to make you do something crazy. So these are all things you guys have heard of, but just to kind of mention, when we think about weight loss, the first thing we're thinking about is lifestyle changes. So physical activity, nutrition. We think a lot about different medications. So most people have heard of Metformin. There's also specific medication targeted for weight loss, things like Orlistat, bariatric surgery, and then actually cognitive behavioral therapy has been shown to be helpful for weight loss. So if you look specifically in women with PCOS, there's been a ton of different studies. In terms of the definition of activity, it really varies from person to person. So the different studies have focused on the CDC guidelines of 150 minutes a week. And this doesn't have to be strenuous exercise. This can be going for a walk during lunch with your coworker. Again, if we're not focusing on sort of any major diet, we're back to kind of deciding, do we count calories or not? And most of the studies looking at weight in women with PCOS have kind of said, let's figure out where you're starting, and then let's decrease the number of calories by about 500. And so studies combining that with lifestyle changes and metformin, which helps decrease the insulin resistance, increases glucose uptake into the liver, decreases the steroid production from the ovaries, have found on average up to 10 pounds weight loss over about 6 months. Compare that to medications like Orlistat, which is actually over the counter and it kind of changes the way your body absorbs fat. And it found that women lose on average about 13 pounds. And in this study, it was 6% of your body weight. And some studies looking at weight loss in general, particularly in women with PCOS, 5% seems to be kind of the magic number. So losing 5% of your body weight is enough to improve periods, to help with hair growth, all of that. So it doesn't have to be high numbers. A lot of people aren't ready to think about bariatric surgery. I think it's a really fantastic option for the right person. We have a really great bariatric surgery center here at UW, and what is great is that they work with people also with weight loss medication, so they're not just kind of funneling people towards surgery, and I've worked very closely with them in the past. In the general population, some people will lose up to 100 or 120 pounds over 12 months. And there have been small studies in women with PCOS which show improvement in all of the things that we're worried about. So periods, hair growth, sexual function. One of the things that's hard about bariatric surgery is if someone wants to get pregnant, then they do typically have to wait at least a year after surgery. You want to make sure that the weight loss is kind of stabilized before you try and get pregnant. And the last thing, which is really interesting, is sort of cognitive behavioral therapy. So I was involved in a study looking specifically at women with PCOS and weight loss, and women were randomized, to either just lifestyle changes or lifestyle changes with cognitive behavioral therapy. Cognitive behavioral therapy is meeting with a psychologist. It's taking the negative emotions and thoughts that kind of impact our behavior. And women lost about 6.5 pounds in 4 months. Do I need that? Oh no! I'm sorry. So how far back do I have to go? Should I start reading this? I'm just kidding. Okay. That would be really boring. Okay. So again, lots of different options in terms of weight loss. My goal overall, in talking to people is it's important to have hope. that it's important to start small. Again, aim for something sustainable over the long term. I work closely with a health psychologist who talks to people a lot about mindful eating, kind of avoiding emotional eating. And I think it's helpful to work with friends and family. I've known people who, again, have partnered with someone at their work and they both took turns bringing in food from home instead of going out to lunch every day. And a lot of those little things can have big impacts. I also think it's important to focus on how you feel and not just the number on the scale. I had someone the other day who, was looking at losing weight and was disappointed that she hadn't lost as much as she was hoping, but she went from being pre-diabetic to normal, and that's incredible. So again, you're not always seeing the weight loss that you want to see, but that doesn't mean that it's not still helping behind the scenes with a lot of things that are going on. So you don't want to ever give up. Just because you feel like whatever exercise you're doing isn't making a difference, it probably still is. It's all still good. And so the goal, sort of homework, when people go home, think about, what your goals are. And it doesn't have to be about weight loss. It can be about any of these things. And sort of thinking about what's something that you have been thinking about trying that you feel like maybe now is the time to work towards. Switching gears completely, so thinking a little bit about irregular periods, again, one of the diagnostic criteria for PCOS. We all wish that we didn't have periods. So a lot of times people come in and, they haven't had a period a couple months and that's fabulous. Unfortunately, generally women should be getting periods about every 3 months if they're not on birth control, because otherwise they're at increased risk of overgrowth of the lining of the uterus, which can lead to hyperplasia or even cancer. There's a lot of different options for this. Again, as I said, weight loss can sometimes improve periods. I've also had people who lost 20 pounds and nothing changed with their period. So it's different for everybody, and what sort of works for one of your concerns might not work for all of them. Birth control pills, as I mentioned, can help change the binding of testosterone in your blood. I'm a huge fan of the IUD, so progesterone only, locally in your uterus, not getting any other sort of systemic hormones, keeps the lining thin, leave it in and forget about it. If someone can't be on estrogen-containing birth control, we have progesterone only, even things like the Depo shot. So it's really working and seeing how often are the periods coming. Someone who gets a period every other month might meet criteria for PCOS, but might not need to be on something to regulate their periods because their uterus is shedding often enough that it's fine. Someone who's trying to get pregnant obviously shouldn't be on any of these things, and then we'll kind of help you through that. In terms of things like elevated hair growth, it really varies. So some people have a little bit, they're able to pluck or shave and it's not that big of a deal, and for some people it's incredibly distressing. So one of the myths, again, is that women with normal testosterone don't have to worry about hair growth. Well, what's interesting / annoying about PCOS is it's not just always elevated testosterone in the blood. Sometimes it's also that the hair follicles are actually extra sensitive to even normal levels of testosterone. So when we think about treatment options for hair growth, there's things like laser hair removal, again, weight loss, or different medications. So birth control pills can definitely help with hair growth. One medication that I use a lot is something called spironolactone. So it impacts the binding to the androgen receptor. Unfortunately, it can cause birth defects in babies, so you can't be on it if you're trying to get pregnant, and so really you need to be on birth control with it. As long as you're on birth control, totally fine, but you don't want to ever start it and then accidentally get pregnant. These are typically the things that I'll kind of do as first line with women. If we're still having difficulty controlling it, that's when talking with a dermatologist is really helpful. So I have a lot of people that I send women to. There are other creams and things that work well. It's expensive, unfortunately, which is why I don't typically prescribe it, because I don't want to prescribe something that's expensive without having you talk to a dermatologist. So that's usually kind of where I start working with other people. Fertility. So I see a lot of women who come to see me and they're at all different stages. You know, they might be 17 years old and they're not sexually active and they have no interest in this, but they're reading online or they were told by someone, you're never gonna get pregnant. So they're not planning on getting pregnant right now, but they're really stressed about it. The good news is there are actually inexpensive medications that can help women ovulate and help them get pregnant. So if we think back to that sort of middle school graph, I should have put it back up here, that follicle stimulating hormone that the brain is making, there are medications that can get your brain to naturally make more of that same hormone and can get you to ovulate. If that doesn't work, we can give women injections of follicle stimulating hormone itself, again, to help them ovulate. These are a lot of the concerns that I've heard from women with PCOS who are trying to get pregnant. I haven't had a period in 6 months, so I don't know when to have intercourse. Usually, if you haven't been getting regular periods, it typically means that you're not ovulating. So someone like this, similar to the third one, you know, someone who pees on the ovulation predictor kit and never gets a positive, that's someone who really needs one of those medications to help get them to ovulate. So the most important thing I tell young women with PCOS who have no interest in getting pregnant is, in 10 years, when you're ready, don't wait years. If you stop your birth control pills and your periods don't come see me after 3 months. You know, don't wait a year, because this whole time that you're kind of sitting here is sort of wasted time if you're not ovulating. There's a lot of concern about progesterone and PCOS, and so a lot of people ask me about progesterone supplementation. Progesterone is a hormone that goes up after you ovulate. So when women with PCOS, if they're not ovulating, it stays low. But it's not, their problems aren't caused by the progesterone. The progesterone is sort of this innocent bystander. And if I can get them to ovulate, the progesterone will rise on its own normally. So there are plenty of times I use progesterone to help people get periods and other things, but it's not something that in of itself is going to help someone get pregnant. And the other question is, you know, what about other fertility tests? You know, I saw someone recently who gets 1 period a year. Best I can tell, her eggs have never been exposed to sperm. So we have to decide, do we test the sperm? Do we test her fallopian tubes? Do we test her uterus? And a lot of those are really personal decisions depending on someone's history and kind of their level of anxiety and frustration with the whole process and desire to know the answer to these questions. So I really individualize that for each person, and the answer for a lot of women is no, that you don't necessarily have to start with expensive medications or expensive tests. We can give you medications, help get you to ovulate, and that sometimes is enough. So again, if you want to get pregnant now, talk to your doctor. So if you're kind of thinking, you're not sure, maybe I have PCOS, maybe I don't, the first thing to do is, you know, talk about your periods, figure out their regularity, you know, think about whether you meet criteria for hair growth, see if there's other lab tests you need to get done. Not everybody needs an ultrasound. So particularly someone who's young, is not sexually active, if they meet the other criteria, we don't necessarily have to do an ultrasound. Someone who we're kind of on the border and we're trying to decide if they have PCOS or not, an ultrasound is super helpful. But again, if you have irregular periods and abnormal hair growth, then you meet the criteria without the ultrasound. And then really screening for all of the other health conditions, things like diabetes, cholesterol, all of that kind of stuff. I'm gonna like quickly click on so that nobody gets stressed. As they mentioned, we have a clinic at Generations that I started that the goal is kind of to bring together all of the different providers who might be able to help women with PCOS in one visit so that you're not having to go around to different places. So I work with Dr. Diem, who's a health psychologist, and Dr. Sood, who's a medical endocrinologist. We're hoping to get a nutritionist because that's obviously an important part of all of this, but that hasn't been worked out quite yet. So when women come to see us, we have them fill out a bunch of questionnaires ahead of time, thinking about depression, anxiety, quality of life, sleep apnea, stress. Check through all of their records. At that visit, they meet with all of us. It's obviously a little bit exhausting, but hopefully better than 3 separate appointments. And then what's nice is afterwards you can come see all of us in the clinic or could see different people individually. Kind of consider it as a home base where then we can refer people to other kind of specialties and work with them. Before I finish, I just wanted to kind of tell you a story about a patient of mine who kind of inspired me and has kind of encouraged me throughout this process. So she came to see me maybe around 9 to 12 months ago. Had bad hair growth, was frustrated about her weight, was on birth control pills, but was having headaches with them. Not at that point trying to get pregnant. And there was kind of so much for us to talk about the first visit that we had to figure out, like, what are my priorities? What are your priorities? What are we going to tackle now? And, let's come back in a month. And so I saw her multiple times over the course of 6 to 9 months. We tweaked her birth control pills, started spironolactone for the hair growth. She screened positive for sleep apnea and ended up needing CPAP. Initially, depression and anxiety scores were pretty high, even though she didn't really have an official diagnosis. And throughout all of this, as we kind of kept coming back, she wasn't losing weight initially. We didn't see improvement in hair growth initially, but we had kind of the constant contact where we were checking in and following each other and working together. And then after a little bit of time, all of a sudden, I realized that her depression scores were going down. And then the next visit, we realized that she had lost 4 pounds. And she said to me, I finally like myself again. And I wrote it down and taped it to the board, because that is what this is all about. It is not just about weight loss or just about one thing or the other or getting pregnant. Sometimes none of those things change, but it's about you kind of feeling good about yourself with all of this and what we can do to help you. So I think that's it. So I'm happy to take any questions. Do you want I can start shouting. I saw you, but I wasn't sure if you were going up or if you were just smoothing down your hair.
I right before I got here, and I've got flowers from my tree in my hair, and it's driving me crazy. So
I was like, is that our signal? I don't know.
I'm trying to beat the rain and trying to get at least another section of my body.
That's okay. Hair and flowers are good. Sorry. Yes.
Hi, thank you so much for the
Yeah.
talk. I have a couple of questions.
Please.
Maybe I can approach you afterwards with the rest of them, but I guess I'll ask 2 in 1. So if someone's taking oral contraception for their treatment, is there a particular combination or strength of oral contraception that you would recommend for particularly PCOS? And my second question is, if there's any risk of the remaining eggs that are in the ovaries and at the time that a person chooses to try and get pregnant, is there an increased risk that there may be some genetic abnormalities in the remaining eggs other than what we know already with increasing age? I just turned 35 and that's one of my
Oops, am I doing okay here? Really good question. So in terms of birth control pills, I mentioned there was this big international consensus guidelines with all the experts, and they basically were like, there is not one birth control pill that's better than the others. There's 2 things to consider. One, I think, is the continuous versus monthly cycling. So some women with PCOS don't like the kind of placebo week that they get in regular birth control pills, where the estrogen and hormones kind of drop down. So taking birth control pills continuously for 3 months and then stopping and getting a period can help with that. You can do that with any birth control pill. There are some formulations that have it built into the pack that make it a little bit easier. There are a couple birth control pills that have specifically been approved for treatment of acne. One of them is Ieds. I don't know if people have heard of Ieds. It was really in favor years ago, and then there were studies that came out about potentially increased risk of blood clots. So I think the most important thing to know is the highest risk of blood clot is with pregnancy. So any risk with birth control pills is way less than that, but some birth control pills have slightly higher risks. So for that reason, I'm very supportive of Ieds, but I don't typically start it as first line. There are different progestins, so the progesterone component of birth control pills that have different levels of what we call androgenicity, meaning the way that they kind of stimulate the hormones like testosterone. And so I typically try and pick a birth control pill that has a lower androgenicity, type of progestin. So one of my favorites is progesterone called Norgestimate. It's in pills like Sprintec. But when someone comes to see me, if they're happy on their birth control pill, I don't typically switch them. I've also had people who I picked what I was like, this is, I'm gonna try it, this is my best guess, and they didn't like it, and then we switched to something else. So there's nothing really magic. All of them, it's the estrogen component that helps with that binding hormone that I was talking about that lowers testosterone. So all of them have estrogen, and then it's kind of picking the progesterone that fits best with your body. And so sometimes it's Norgestimate and sometimes it's levonorgestrel, which is the one that is the most androgenic. And some people, they love it. So it varies. In terms of eggs and things like that, I think it's important to think about what happens in a normal cycle. So you have, say someone has 20 follicles and they're actually ovulating. One of those follicles will grow, they'll release a mature egg, the other 19 actually die off. And that's the same as whether you have 20 and you have 19 that die off or you have 10 and 9 die off. And that's why we are all born with millions of eggs. So none of the things that we do slows that down or changes it. So someone with PCOS, even if they're not ovulating, typically their eggs are kind of undergoing that dying off at the same rate as someone else. I do find that women with PCOS have good ovarian reserve, so a good number of follicles for longer. So someone who comes to see me who's 40 who has PCOS might potentially have more eggs than someone who's 36 without PCOS, which is kind of nice from a fertility standpoint. In terms of other kind of chromosome abnormalities, there's no evidence that things like risk of Down syndrome or stuff like that are higher in women with PCOS. There's potentially an increased risk of miscarriage when we start thinking about pregnancy complications. Some of that sometimes is related to weight and sometimes it's not. So there is that kind of risk, and a lot of miscarriages are because chromosomes are abnormal, but no increased risk really of having a baby that's abnormal. That answers
Thank
questions.
you. Just a really quick follow-up
Yeah.
then with the birth control pills. I know
Please.
there are some that are low
Yeah.
estrogen, for example, it's a lower level of estrogen. And for people with PCOS, is that okay? Is that frowned upon? Is it better? Does it matter?
I hate to say it doesn't matter. When there's 50 birth control pills, I wish that it was the best. I think there's a couple things to consider with doses of estrogen. So we said that estrogen in these situations is good, but estrogen is also what increases risks of blood clots. And sometimes women who are overweight have increased risk of blood clots, women with problems with blood pressure. So there's a lot of kind of things that I have to think about when you're deciding the dose. Overall, whether it's 10 or 35 of the ethinyl estradiol, those are all still really considered a low dose. So the birth control that I like with the Norgestimate actually only comes in sort of the 35, which is the higher dose of estrogen. So I'm typically okay with that. If someone's on something that's lower and feels like they're not getting enough kind of hair growth, then sometimes I'll increase it or change things around. But I would say that generally we aim towards low because that's good for risks of blood clot, but knowing that there's not despite being a million types of birth control, there's not always the right combination of the progesterone I want for someone with the estrogen dose I want, if that makes sense.
Can you please speak on PCOS during menopause and after?
Yeah.
What are the things that we need to watch for?
Yeah.
What are the things, for example, I've been on Metformin forever.
Yeah.
Do you keep the same doses? Do you change? Because diabetes
Yeah.
can lure, there's so many things as you show.
Yeah.
And the body changes and numbers change, including the liver enzymes. And so what kind of lifestyle, medication, what can you speak to?
Yeah.
I probably leave the previous part, so now menopause and after.
Yeah,
what to watch
absolutely.
for.
So the things that improve, and I don't know if you've had this experience, but a lot of women find that as they get older, sometimes the irregular periods improve, sometimes the hair growth improves, or the testosterone levels. So sometimes some symptoms get better, but some of the risks are still there. So the biggest risks that we think about in terms of as someone's going through menopause are risk of diabetes. I typically use metformin in women with PCOS who have like a pre-diabetes or diabetes. So it's always hard to decide. We used to start metformin on everybody, no matter what. And now it's kind of leaning towards maybe using it more in someone who we're trying to decrease risk of diabetes. So I think a lot of it depends on what their diabetes risks are. If someone's been on metformin for a while, but whenever we checked their hemoglobin A1C or their glucose tolerance test, it's been normal, we consider stopping it and see what, repeat those tests and see what they are. And if everything stays normal, then it's possible you don't have to be on it. If people don't want to be taking a million medications, metformin's great, but sometimes it has its own side effects. If someone's on it because someone told them to start it 10 years ago because they had PCOS, I'm more likely to stop it and see how they do than if someone had really bad pre-diabetes for a long period of time and I'm trying to prevent diabetes. I typically screen for, in women of any age, I screen for diabetes and cholesterol every 2 years, and then if something's abnormal, I'll screen for it more frequently. And so a lot of those are some of the normal things that a woman will be screened with at her annual exam. So it's just kind of making sure that we're not forgetting that women with PCOS are sort of at some of those increased risks. All of the stuff that we think about in terms of physical activity, exercise, weight loss, honestly applies to women of all different ages. Most people, if they've gone through menopause, aren't worried about irregular periods, but are sometimes thinking about hormone replacement for hot flashes or other symptoms. All of those things are safe in women with PCOS compared to someone else, as long as there aren't other reasons to do it. But PCOS in of itself isn't a reason not to try some of those medications that help people feel better.
What about heart disease?
So it's really tough. So I was involved in a publication that looked at long-term health risks with PCOS. There have probably been 7 studies looking at heart disease. And so it kind of ranges between looking at things that are markers of heart disease, like fat accumulation, atherosclerosis, and looking at actual heart attacks and stroke. Some studies have shown that there is a difference and some haven't. If you look just at the high quality studies, they haven't actually shown an increased risk. So that either means that these are rare events in women in general and maybe we need bigger studies, or it means that women with PCOS have increased risks of diabetes when they're younger, but then as everyone goes through menopause, that kind of risk goes up, and so someone with PCOS might have been exposed longer to these problems, but that extra time doesn't cause increased risk of heart attack or stroke or things like that. So that's potentially good news. I should lead with that. But the studies, I would say, haven't really been like the quality studies that we would like, the same way it has with some of the other things.
We have one online question that is a good follow-up to this one, I think, which was, so post-menopause with a little bit of hair growth, would you recommend I'm going to butcher the pronunciation, spiro something?
The spironolactone.
Thank you very much. Would you recommend that for post-menopause with a little bit of hair growth?
Yeah, I think that's a great question. So it depends on how much it is, how distressing it is, all of that. If you're thinking about treatment options, then at that point, we're kind of moved away from first line stuff like birth control. Spironolactone is actually kind of in the diuretic antihypertensive family, so it's not first-line treatment for high blood pressure, but it's one of those that kind of falls along that group. So one of the things to think about is sort of what someone's blood pressure is. You know, we want to make sure that someone's not hypotensive and we're starting that kind of medication. It also can impact the kidneys, so it's cleared, when it's sort of cleared by your body, it can impact your body's ability to clear electrolytes like potassium and things like this. It's not something that I worry about in someone who's 30, but if someone's 60 or 70 and they have any other health complications that might impact their kidney and stuff already, I might need to follow them more closely. So starting with, if you're considering doing spironolactone, someone who's post-menopause, you know, checking to see what their kidney function is, what their electrolytes are, making sure that that's normal, starting the medication, and then potentially following up with those labs in a month to make sure that they are still normal. So I would follow people a little bit more closely in that kind of situation, but otherwise, no reason to say that you couldn't do it.
I could probably shout louder than this, but, if somebody were, let's say, I'm perimenopausal, when I was diagnosed a long time ago, this was like, oh, you just have amenorrhea. I'm not going to murder his name.
Amenorrhea, oligomenorrhea,
Yeah.
I know, all these great
And that's what they told me. And all they did back then is hand you the drugs and say, here, go. They didn't give you any side effects, they didn't give you anything. I was probably 135 at the time and kept increasing because of the medications. I have been on metformin. I can't be on metformin because it makes me sicker than a dog. And so in somebody like me, how would you help the PCOS? I mean, I have other things, but I won't bring it up here. But is there something that you could? Is there some way that we could? Because I'm not planning on any more kids. Okay,
Yes.
mine's 28. Take my word for it. I don't want any more kids. So is there something that you could do to help somebody like me to get that I've been diagnosed with PCOS and everything you said up there? I could probably go, yep. You and I would have a very long conversation.
My favorite topic. The first thing, before I even answer your question, I just want to say that there are a lot of people who sort of are saying, I was diagnosed a really long time ago, and I didn't have an ultrasound or blood tests, but I meet some of the other criteria. And so sometimes it's hard to know, and so we are kind of able to retrospectively diagnose someone if we get a good history of what their periods were like and what their hair growth was like. Otherwise, you know, in terms of kind of treatment options, a lot of it is focusing on some of the same things that we were talking about before. Birth control pills in the perimenopause stage, depending on other health risks, can sometimes be okay and can sometimes kind of help tide you through those kind of difficult times. Again, you know, hormone replacement, those kind of things, depending on other health risks. At the end, it's really tough because there's nothing magic. Like, there's nothing here that, you know, I wish there was a lot of better natural vitamin options, things like that. And so I think a lot of it is really focusing on what are our main concerns. So if the main concerns are hair growth, then it's kind of deciding, okay, what have we tried? Do we want to try spironolactone? Do we want to get you connected with a dermatologist? Do we want to try laser? We can do that at any age. Are we focused on, you know, weight? So what can we do to help with weight gain? What have we tried in the past? You know, you've probably tried a lot, and there's probably a lot that you could tell me about what does and doesn't work for you. So kind of figuring out, like, what else is there that we could do? And then really focusing on, are there other kind of health risks that could be going along with things? Things like sleep apnea, you know, so I screen every woman with PCOS for sleep apnea. It's amazing to see how many people turn positive, and that impacts blood pressure, it impacts quality of life, it impacts ability to exercise and things like that. So I think those are important to think about in women of every age, but especially as someone's getting older and some of those risks might increase. Sorry, it's not magic.
No, I didn't expect it.
Hi. I actually came because I wanted information for my daughter, but as I'm sitting here at 65, I was told in my 20s I had PCOS, but it didn't really at that time, like you're saying, you know, they had me in the head and said, have a nice life. So listening to this, I did have preeclampsia, I had gestational diabetes, and I just had a hysterectomy for stage 1 endometrial cancer. So I guess I've had it all these years. However, my daughter now, she really is very symptomatic. She's gained a tremendous amount of weight. She's got very much pursuit, and I want the information to help her. But she also has Hashimoto's thyroiditis. So is there something that in the autoimmune family, since this predisposes you to diabetes, does this impact other autoimmune conditions?
That's a great question. So the things that we haven't talked about in terms of like how PCOS comes about, there's a big question about things like inflammation, which is slightly different than autoimmune, but still kind of along those same lines. So thinking about inflammation and how that might cause PCOS. Women with PCOS have elevated sometimes white counts in their body. They have elevated vitamin D level or impact the vitamin D levels. C-reactive protein, which can impact risk of heart disease and things like that. So there's definitely an inflammatory association. I have not heard specifically of an autoimmune association. I mean, that's a really good question because, like you said, things like diabetes, but I don't know for sure. The thyroid is tough because it can sometimes make PCOS diagnosis difficult because it can also cause irregular periods, so we really have to make sure that we normalize the thyroid as we're also focusing on so many of the other symptoms because they can kind of go hand in hand. But yeah, good question, I don't know. You stumped me.
We've had several online, so I'm just going to see if we can burn through a couple of those, and then we'll move back to the room questions. It's wonderful that we have so much engagement today. We will start with a question from Katie. Will you lose weight if you go back on birth control after having kids because it would lower your testosterone?
That's a really good question. There have been studies looking at birth control in women with PCOS and weight loss. And unfortunately, it doesn't seem like it really makes a difference. So it helps with a lot of different symptoms like we've talked about. Weight loss is probably not one of them. I truly believe that birth control pills don't make someone gain weight, so I feel very comfortable starting them in people. There have been a lot of studies that show that they don't gain weight, but I unfortunately don't think they help with weight loss.
Another one from Rachel this time. Wondering your thoughts on Myo-Inositol. I'm going to say these wrong again. Thank you for all your medication names. And D-Chiro supplements.
Yeah, it's also a super good question. So I don't know if people have heard about inositol before. You probably have. It's all over the internet. It works kind of in the same vein as metformin. The goal is kind of trying to help with the insulin resistance. There have been a lot of different studies looking at them, those medications in PCOS, a lot of different studies looking at like ratios of different types of formulations in PCOS. Some have shown improvement and some haven't. The overall sort of official guidelines are that they're not magic and that we shouldn't be recommending them to everybody. That being said, I think that they're probably low risk. I think that there's a theoretical potential benefit based on how they work. Some studies have shown a benefit, it's just that it's not consistent around all of the studies. So typically if someone wants to start them, I'm supportive, but it's not something that I recommend like off the bat to everybody. Supplements in general aren't regulated by the FDA, which means that we don't know for sure what's in it, and that makes it kind of hard to study stuff. So totally fine for you to do, but not something that I would specifically say I have a magic dose or formulation for, unfortunately.
Can you speak specifically to the side effects of metformin? As a long-time sufferer, new-time diagnosee, I'm still reeling over having to take metformin and waking up in the morning feeling like I have to vomit all the time and having digestive issues all the time. Is there any method of madness that I could try to follow to minimize that, food or taking it at the right time or anything like that?
Metformin sometimes just stinks. It works for some people and some people like we can never find the right dose. I typically do the extended release version as opposed to the immediate release because that obviously can help sort of control the delivery. I typically start out slow, so I'll start off at 1 pill, so the 500 for a week, and if someone can tolerate it, I'll increase it. And if you're not, then I'll go back down, and sometimes you need a whole month at the lower dose before you can kind of go up. And some people can never go up to 1,500 or 2,000, and they have to always kind of be at the lower dose. I typically say to take it sort of at bedtime, and that's really it. I've had people who just can't tolerate it. And if that's the case and we're doing it for management of prediabetes, then sometimes we say, okay, do we just keep checking and screening you? And if things get worse, we sort of actually treat for diabetes, or do we try one of the other sort of medications that we use for diabetes, glyburide, things like that are different than metformin. So that's where helping, with the medical endocrinologist, people who treat diabetes can sometimes be helpful because then they can kind of say, okay, if metformin doesn't work, what would be a good second line? But no, I truly have some people who can never take it, or who hate it, or have to stay at low doses. So don't beat yourself up. If you can't do it, it's not magic. None of this stuff is. Don't stay on it if you hate it. You have my permission.
2 questions. What is the relative risk of developing diabetes with a diagnosis? And then second, in terms of kind of that lean phenotype, is there evidence that even if you have a BMI under 25, if you lose weight, does that increase fertility or improve symptoms?
Yeah. So the risk of diabetes in women with PCOS is about 2-fold higher than someone without PCOS, and it's pretty consistent, again, regardless of weight. So 2 to 3 times higher in all different kind of weight classes. It's tough because someone who has kind of a lean phenotype, we don't know if there's something different underlying the physiology. I mean, I just showed pictures of like 4 different things, and so someday we might separate some of these out, and there might be people who have PCOS that are different, in terms of their physiology than other people. Generally, I just recommend people be active. So someone who has a lean phenotype but isn't eating healthily or isn't getting up and moving around, that's probably not good for some of these risks. If you're able to exercise more, walk, eat healthy, even if you don't lose any weight, it's going to be helping some of those behind the scenes. Whether it helps for periods and fertility, I would say probably not. If someone already is kind of the normal range, losing 5 to 10 pounds, too much can be bad too. You don't want to go BMI to be too low.
No, give it back to me. Just kind of a quick thing on metformin again. So I'm kind of in that limbo between wanting to get pregnant, not sure yet, and so I've been on the metformin for 4 years now, at 750 twice a day, and it regulates my periods pretty well. Is that something that if it's working, but I don't necessarily need it for the insulin resistance, that it's okay to kind of keep taking then, as long as it's working with that?
Yeah, absolutely. So I think we haven't talked much about PCO or metformin and periods. Mm-hmm. So it does seem to help regulate periods in some people, and so it can, if someone has really irregular periods, help regulate them. And if you're doing well on it, I think that the risks are at this point. You guys can get together and chat. If you're doing well on it, the risks of continuing it are pretty small. In terms of metformin and those regular periods and fertility, there have been really good studies looking at metformin compared to some of the other medications, things like Clomid or Letrozole. And even if you have regular periods and you're actually ovulating, chances of pregnancy are lower. So just because you're on metformin and you're kind of getting periods with it, doesn't mean that it's actually helping with fertility. So it can help with periods and fertility kind of separately. So typically if someone's on it and they're doing well and they like it, I don't stop it. I'm supportive of people stopping it if they want to, but if you're happy with it, I don't make you. I typically stop it when someone does get pregnant. So I won't continue it through pregnancy. So if you were to get pregnant on your own, especially if you were started on it for PCOS and not insulin resistance or diabetes, just stop when you get pregnant.
Cool. This microphone is super dead. And I'm tracked. This is all really good. I have the questions on my phone.
Oh, great.
Ask them into the mic up there so people know what we're working on. And if we have more room questions.
That sounds good. Okay, thank you all for bearing with us. We didn't get to choose the microphone, it just sort of died on its own. Okay, we've had several really, really good online questions. So I wanted to start with Val's question of are PCOS and endometriosis related, and could one cause the other?
Great question. Best we can tell, no. So endometriosis is when the lining of the uterus kind of makes its way into the pelvis. When your lining grows and sheds each month, that those sort of spots of kind of abnormal lining in your pelvis also grow and shed, and it causes a lot of pain. So they don't seem to necessarily be connected, but they show up in a lot of the same situations. So both of them can have impacts on fertility. So a lot of times I'm seeing women who might have both of them who are trying to get pregnant. But generally PCOS is considered to be a painless condition and sort of unrelated to endometriosis. They both can be treated sometimes in birth control pills. So again, there's a lot of things that go together that we're working with, but no reason to think that if you have one, you're more likely to have the other. It's just bad luck.
But it is possible.
Oh, it's incredibly possible. Oh yes, I mean, because if you think about how common PCOS is, endometriosis is also incredibly common. So very common for people to have both, absolutely.
And you said PCOS is supposed to be painless.
Yes, it is supposed to be painless. Now, that being said, if someone only gets a period every 3 months, then their lining is filling up with that sort of blood, and when they get that period, everybody knows it is just miserable, right? So it's heavy, people will bleed for a month, and it's really painful. That is different because that's not pain from the PCOS, that's pain from like your uterus pushing out the blood. The pain that people get with endometriosis typically starts before the period, so before you even start to bleed, and actually kind of gets better as the bleeding starts, typically because that kind of hormones that are causing the bleed and causing that everything going on in your pelvis is getting better. And sometimes if it gets worse, they'll have pain throughout the cycle. That shouldn't be PCOS. Pain with intercourse, pain with bowel movements, all of those are seen with endometriosis, blood in your stool. That stuff shouldn't be seen with PCOS. Cool. Yeah, sorry.
Is there a certain medication you typically recommend for stimulating ovulation in someone with irregular periods who does not regularly ovulate?
Yes, so the answer is 100% letrozole. So there's a couple of main medications, Clomid and letrozole. Clomid used to be the one that everyone used. There have been good studies in women with PCOS comparing the two, and letrozole works better. That being said, if someone doesn't ovulate to letrozole, then I'll try Clomid. So it doesn't mean it doesn't work, it's just not what I start with first. If that doesn't work, then typically we're talking about injections of follicle stimulating hormone. Women with PCOS have tons of follicles, so I can almost always get them to ovulate. It doesn't always happen the first month. Sometimes it's incredibly frustrating and it takes a little bit of time, but we can usually get it to happen.
Another question, this one from Christy online. Do IUDs come in hormone-specific varieties, like if we just wanted one with progesterone, is that a possibility?
Yes, so there are two types of IUDs. Copper, which has no hormones, which is great for birth control, but I don't typically use in women with PCOS, and multiple different progesterone-only types. So nothing will actually come in an estrogen type of IUD. They all have progesterone, only, and they're great. Put it in, you forget about it. You can leave it in for 5 to 7 years, and it helps with the lining. So yeah, progesterone only. The main names are Mirena and Liletta. You ask your doctor.
Any more room questions before? Yeah.
So I know we don't have a very good understanding of what causes PCOS, but what I'm wondering is if it starts, in your mother's womb or whatever, does that mean that a girl is often born with PCOS and then it just kind of shows up when, you know, she begins getting her period and whatnot? Or does it essentially start when that happens? Is there like a trigger that would initiate PCOS?
So the question, just for people who are listening, is, you know, if we think that the exposure when you're in your mom's womb kind of is one of the things that can affect, you know, cause PCOS, if someone is born with PCOS, or if there's something else that might happen later in life that triggers it. I would say it's hard to know for sure, because women who haven't gone through menarche, haven't gotten their periods, you know, a lot of times they don't have this criteria. But I would say that there's definitely some, you know, moms who have PCOS, there's things that we can see in younger girls even before they go through periods related to, you know, risk of things like diabetes, weight gain, even again before they get periods, that make us think that there might be something going on hormonally. But it's not just a one, people talk about this in science, like this two-hit hypothesis, where it's not just like one thing that caused it. And I would suspect that a lot of the time it's like whatever happened genetically or while you were in your mom kind of predisposed you, you were at higher risk, but you could be a twin, and not all twins have PCOS. So identical twins are more likely to both have it, but they don't all. So there's definitely something later on that happens that we don't understand. Yeah, tough. You get to decide. I'm just here for
This is too much pressure.
Okay, my daughter has PCOS, and basically spironolactone and birth control work very well for her. She has iron levels in her blood of free iron that are through the roof. Is there a connection to this?
So the question was, daughter with PCOS on birth control and spironolactone doing well, and has elevated iron levels. It's a good question. I've never heard birth control affecting iron levels. And I wouldn't think that, I know that, you know, again, spironolactone affects kidneys. If her kidney function and everything else is normal, I mean, I would check that. If kidney function is normal, then I wouldn't think that iron levels would be elevated.
I'm a pharmacist, so I pretty well know the drug part.
I know, so between the two of us, we should figure this out.
That's why this comes from so left field. That but it's nothing, you don't see it in your stuff.
I have never seen it before, no. So if it is, we can write it up, tell everybody else about it.
Are women with PCOS treated differently during pregnancy? Like, are there still high androgen levels, and is that treated during pregnancy?
Great. So the question was, are women with PCOS treated differently during pregnancy, and if there are higher androgen levels, if that's treated differently? Not really. So they are high risk for things like preeclampsia, gestational diabetes. Sometimes when we think about screening for gestational diabetes, the typical screening is 28 weeks. Sometimes in women with PCOS, they'll screen earlier, so at 12 weeks. What they're looking for there is whether someone had like maybe undiagnosed diabetes ahead of time. All of my women, when they're coming in to get pregnant, I screen them ahead of time, so we already know if they do or don't have pre-existing diabetes, so really the gestational diabetes in the third trimester screening should be fine. We don't know much about testosterone and how it affects women when they're pregnant. The studies, I'm hesitant to like repeat mouse studies and like scare people. The studies that I've alluded to about like exposure when your mom is pregnant have looked at anti-Müllerian hormone levels. So something we haven't mentioned yet, but it's a hormone made by all those small follicles, and it's generally higher in women with PCOS. And mice with high levels of anti-Müllerian hormone have an increased risk of having kids with girls with PCOS. People have asked, like, is there something I can do to suppress that? And at this point, the answer is no. So it's really hard to know that there's an increased risk of your daughter having PCOS if you do, and not being able to do anything about it. They're looking at medications to help decrease that risk, and we just don't know. They're also looking there's a doctor at UW who's enrolling, I don't know if he still is, but was looking at pregnant women and doing like little of the babies, like scalp biopsies to look at androgen levels in the kids. I'm sorry, not a scalp biopsy, taking a little haircut. Cut of the hair, not the scalp. That sounds scary. I saw your face. And looking at androgen levels, so again, seeing like how does the mom's androgen level affect the kids. So that stuff is just like a really sort of hot topic of conversation. And then otherwise screening for things like preeclampsia, you're going to be checking your blood pressure every visit. If things are elevated, they'll do what they would normally do with preeclampsia.
Excellent, thank you.
Yeah. If you have PCOS, what age would you screen your daughter for?
At this point, nothing. So I would do anything that you would do for any kid. You know, you give them love and you make them happy. You teach them to be active. You sort of model good behaviors in terms of physical activity and exercise. You model good behaviors in terms of body image, you know, and how you feel about yourself, and sort of teach her that everybody is great. And then see what happens when she gets her period. And that's the best we can do. And kind of don't let anybody make, you know, mistakes that might have been made with you, where it takes you years and years to get diagnosed, sort of have it in the back of your mind. But also don't obsess with it. You know, I've had people who come in with young girls who have sort of said, I had PCOS, and they're just so worried about their daughter having PCOS that they're focusing in on a lot. Keep it in the back of your mind, but don't stress. Let her go through her young life. She's probably going to be fine. You're great.
I think this is an important question that's probably on a lot of minds in this room and definitely several people online. How do people get appointments at the PCOS clinic if they want to see you? And then an addendum that is actually my question. At what life stage do you see patients? Do you focus mainly on fertility practice, or can people come to you basically at any age?
Yeah, good question. So the get appointments, you call our office, so Generations Fertility. If you have PCOS and you're interested in getting pregnant, typically I'll start by having people just see me instead of coming to the main clinic. You could, but sometimes it's nice to get, if someone's really anxious about fertility, sometimes it's nice to get some of that fertility conversation out of the way. And then if we feel like we want to get you to see everybody, then I'll help get you set up in the clinic. If you're not interested in getting pregnant, or if you're really sort of more focused on some of the other issues, then when you speak to the schedulers, you just sort of say, I'm not interested in getting pregnant, I want to be seen in the general PCOS clinic. I wish I could say that like there are appointments tomorrow. We are booking out a little bit, which is good and bad. You know, when we started this clinic, the first couple of days that we would be like twiddling our thumbs and like, I know there are PCOS patients, where are they? And now there are a lot of people to be seen. So I think one of the things that I want to do is not just, you know, talk to your doctor, call us, schedule an appointment, but also talk to your doctor. You know, a lot of early things can kind of be managed with primary care or OBGYNs now that you guys are more educated and know what to think about. So I don't want to take you away from your other doctors. I like to work really well with community physicians and, you know, help give them guidance and stuff about what to do next. But even if it takes you a couple months to see us, we're happy to see everybody. In terms of ages of women that we see, it's a tough balance, because at the end of the day, a lot of my focus and training has been on reproductive age women, with some kind of understanding and thoughts about what to do with women with PCOS, specifically who are perimenopausal. But we don't have a lot of the resources that people need for general GYN care, so things like doing a pap smear, even thinking about mammograms and some of that kind of stuff. I'm not any longer a general gynecologist, and so we don't have those kind of set up for things. So someone still needs to make sure that they have a gynecologist that they're working with. So there are women physicians in the system. Dr. McCable Williams has specifically a menopause clinic, and so sometimes depending on what someone's concerns are, if they're worried more about hot flashes and they happen to have PCOS, they're best served seeing her and then kind of talking to me about different things. If they're worried more about hair growth, then maybe coming to see us could be nice. Obviously, the endocrinologist and health psychologist I work with, they have no specific cutoffs for anything, and so that's kind of nice as a team that even if there are health concerns that I don't typically think about in someone who's postmenopausal, the endocrinologist kind of has my back, if that answers questions.
I have one more.
Yeah.
Where does PCOS sits in the body? Like most?
Where does it what?
Sits in the body or is housed in the body. Like if a woman has a hysterectomy, does PCOS resolve and disappear, or you know what I mean?
I know exactly what you mean. So I was at there's this group of people who like PCOS, but want to make it better. This PCOS and Androgen Excess Society, and so I was at a meeting the other year, and they had as one of their lectures this debate as who is at fault? Is the ovary the one that's at fault, or is it something else? The brain or other glands or things like that. So in that sense, we don't really know. It is definitely not something where if you remove the ovaries and remove the uterus, that symptoms get better. So endometrial hyperplasia, cancer, definitely hysterectomy is gonna, treat that. But if you remove the ovaries, the estrogen is super important for cardiac health. It's super important for bone health. So you still need all of those kind of things. Some of the testosterone is being made by the ovaries, and sometimes it's being made by the adrenal glands. So there's other parts of the body that are still contributing to the testosterone. And as bad as PCOS is, I feel the risks of heart attack and things like that by removing the ovaries and getting rid of the estrogen are worse. So it's never something that I've recommended as a treatment.
What about the uterus?
The uterus is just an innocent bystander. So really, it's, the uterus is only responding to the ovaries. So if the ovaries ovulate and tell the uterus to make hormones and shed, it'll shed. If the ovaries don't, it won't, and it'll just grow. So the times to remove it are if there's hyperplasia or cancer. Otherwise, the goal is to keep the lining thin and let the ovaries work on the other stuff.
Okay, thank you.
Sarah, do you have a question?
This is a good follow-up, actually. So there's been a lot of research and discussion lately about the microbiome and how dysbiosis in the microbiome can result in inflammatory conditions, autoimmune, a lot of mental wellness issues as well, because they're discovering the microbiome is actually responsible for making serotonin and dopamine and et cetera. And as you had mentioned, that there's an inflammatory component to this, which was news to me. And so I'm wondering if you can comment on any studies that you've seen, if there's a link there, and if cortisol levels have been seen to be chronically elevated in people with PCOS, because it's kind of an area where I'm interested in doing some of my own research.
Yes.
Testing my levels and then taking some pre and probiotics and then retesting them and see if I
that we could do everybody in the room. Just you can't go home. I'm sorry. So the question was about the microbiome, and so the microbiome is just the idea that there's for lack of a better word, little bits of bacteria all over the body, and different parts, the vagina, the gut, have different levels of healthy bacteria, and that in fact impacts things. And so the first question was about microbiome in PCOS, and the second was about cortisol in PCOS. So in terms of the microbiome, there are active studies being done looking at the microbiome in PCOS. Some of the stuff that they're looking at, I saw studies looking at feces of mice with PCOS who've been treated with different medications to get them to ovulate and feeding it to other mice who aren't ovulating to see if it helps them ovulate. That is not yet ready for humans, but it definitely, I think, shows that there probably is something involved. I've seen people who have gotten grants to look at microbiome in PCOS. I have not seen definitive studies. So I think it's really early on. All microbiome stuff, I would say it's really early on. They're probably going to find some kind of association with PCOS, whether it's one of those other second hit things that comes in, or whether it's really the end all be all, I don't know. cortisol. So there have been, this is an interest of mine as well, I will say. There's two things to think about with cortisol. Cushing syndrome is something that mimics PCOS. So when your body is sort of making too much, and in order to screen for Cushing's, you test cortisol levels. So every now and then we'll check someone with PCOS for Cushing's and we'll do like salivary swabs. That's different, that's just a mimicker of PCOS. In terms of women who actually have PCOS and looking at cortisol level, there have probably been, honestly, like 2 studies looking at women with and without PCOS and exposing them to some type of stressor and then checking their cortisol levels before and after. And it seems that women with PCOS compared to those who don't have a sort of hypercortisol response to stress. So cortisol always goes up in response to stress, like that flight or fight. But with PCOS, it seems to go up higher. In the study that I mentioned that we looked at cognitive behavioral therapy in women with PCOS, we had them do a specific sort of stress test, which is actually just like this. So you had to like get up in front of a group of people and talk. And then you also had to do like arithmetic, so it would be like you guys also make me do math. And they checked like cortisol levels before and after. So we were doing this to look at whether cognitive behavioral therapy, in addition to improving weight loss, improved cortisol levels. And it was a small study, but it seemed that cognitive behavioral therapy did improve like the stress responsiveness to this kind of stress test. So small study would have to be repeated. I think there's a lot that needs to be done in PCOS and stress and cortisol, but definitely there's something there. I believe there is.
We have 10 seconds. So, one more question that we can figure out a different way to answer if this doesn't work. How does AMH level relate to PCOS? Like if you have a high AMH, does that mean you have PCOS?
Good question. So AMH was the hormone that we said a little bit ago was made by the small resting follicles. Women with PCOS have a lot of follicles. So a lot of times they have a higher AMH. It will honestly someday be on my list of things that are like part of the criteria. It's not yet because different labs have different assays. So an AMH of 10 in one lab isn't necessarily consistent in another lab. And as much as we would like to think that AMH is like perfect and consistent over time, it's not necessarily, so it does vary. So there's no clear cutoff. So it's not yet part of the diagnostic criteria, but if I see someone who has a higher AMH, makes you think like, okay, let's see what their ultrasound is. I'm going to use the ultrasound to meet criteria. I'm not going to use the AMH, but they go hand in hand. Because PCOS is so heterogeneous, there could be someone with PCOS who has, when I think of AMH, it's really used for fertility. So I want to see a number more than 1 because that means someone has a decent number of follicles and they're going to respond well to my fertility medication stimulation. It otherwise has no other use. So it's literally the use is just to decide doses and response to fertility medication. So when I say if someone has like a normal AMH and PCOS, that's great. I'm not worried about it. Someone could have irregular periods and hair growth and not have a lot of follicles, and so their AMH would be normal. Someone could have really high level of follicles and might have a high AMH. So it goes along with everything, but it doesn't tell me much. I don't do anything differently because of it, but like if you were asking in 10 years, I'll probably tell you there's like a magic cutoff. We don't know yet.
Wow, thank you, Dr. Cooney.